Welcome back to my new video in my channel. And once again, I would like to extend my gratitude to all of you to support my channel for your all love and affection and the subscriptions. Uh, in this short video, which is the continuation as a part 3 of the acute coronary and arrhythmias series. Here we will discuss upon the ECG findings, biomarkers, and of course the imaging, and maybe on supportive management and discussion on antiplatelets. At the outset, I would like to thank the Nepalese Critical Care Society to invite me as a guest international faculty for their NSCCM Critical Care Conference, which was held in Chitwan, Nepal, the last week. And I was so honored and privileged to be a faculty during this conference, deliberating upon various aspects of critical care alongside of the stalwarts in the field of critical care medicine across the globe. So it was a very nice quality time spent with all our international colleagues. So, having said that, uh, without much ado, let us start with this part 3 today. Now, as far as the ECG is concerned, I think it forms an integral part of diagnosis of ACS. So, as we know, a normal ECG does not rule out ACS, and that is the most important point which we need to understand. At the same time, ST depressions or T wave inversions represents ischemia or non-STEMI, and ST elevation is evidence of an injury, which is famously called as STEMI. Q wave in the ECG is indicative of an MI, and not all MIs would have Q waves. So it is always important to look for reciprocal changes and evaluation for axis deviation. As you could see in this ACG is a classical LBBB. So these are a few of the salient features as far as the ECGs are concerned. As I said, uh, if the patient has a non-thrombotic plaque, as you could see, uh, there could be ST depression, and that is the classical non-STEMI. Uh, Whereas if the patient has a partially occluding thrombus or fully occluding thrombus, as you could see here, ECG would show a classical ST elevation, which is suggestive of a STEMI. So these are the two important points which needs to be kind of pondered upon when you encounter ECG of acute coronary syndrome, and this is taken from the very famous NEGM article published in May 2017. As far as non-ischemic conditions which are associated with ST segment elevation on ECG, as you could see, LBBB, which can be one of the cause, along with myocarditis, hyperkalemia, and Takotsubo cardiomyopathy. So don't forget these conditions, which can be mimic of active ischemia on the ECG, and you need to have an individual case-based approach to the patients presenting with such ECG findings with a proper clinical context. As far as the biomarkers are concerned, uh, the quantitative cardiac troponins, the troponin I, which will go up within say 1 or 2 hours of the active ischemia, and they form an important tool to diagnose acute coronary syndrome with the help of the classical history, what we discussed in the earlier parts, along with the ECG findings and putting it all together. It can never be in isolation that you see a troponin which is raised without a classical chest pain, without a classical ECG. Please don't make a mistake of diagnosing myocardial infarction just on the basis of raised troponins. Probably it holds true for any other medical condition, uh, which we need to understand that just one particular aspect of either investigation or diagnostic is not sufficient to diagnose a particular condition. There is another biomarker by the name of copeptin, which is coming up as a diagnostic modality for acute myocardial infarction. As you could see here, with a raised pro BNP, we need to suspect cardiac fibrosis. And same is true for IL-6 or CRP for inflammation, D-dimers and fibrins for coagulation abnormalities, and the troponin CPKMB for myocardial injury. Now, as far as the ST elevation is concerned, the highly sensitive troponin is important. So, when you have a ST elevation on ECG with positive, highly sensitive or specific cardiac troponin, and the change of the cardiac troponins in the first hour is what should raise the suspicion of myocardial infarction or acute coronary syndrome. There are three other novel biomarkers. Uh, so one of them is pregnancy associated plasma protein A or PAPPA, the IGF-1 and IGF-4. As you could see that in 1 year mortality when the CPKMB was high as well as the cardiac troponins were high. So this definitely has a bearing on the prognostication of the ACS. Along with MAC or membrane attack complex, which is released in the blood with the myocardial injury. As you could see, this is a myocyte, along with decrease in the IL-17 and increase in the pentraxin. So these are the remaining novel biomarkers which anyone should remember. Uh, Along with that, of course, we take help of imaging, a fully advanced CT machine with more than say 328 or 326 slice CT machine, which will help us to have a triple rule out, uh, which will rule out the most deadliest clinical conditions like acute myocardial infarction and pulmonary embolism, and of course aortic dissection. So as you could see, even the MRIs would be the kind of a radiological investigation which will help in the risk stratification of the patients of ACS, and of course they will help in accurately diagnosing and detection of ACS. The near infrared spectroscopy also can be helpful in the detection of lipid core as a culprit or a plaque which is larger in STEMI. So this is by and large the radiological investigations helpful in diagnosing ACS. Now, a bit on supportive management, and as we know, uh, that this goes by a mnemonic as Mona, and we relate this particular word with the famous villain Ajit, uh, where his dialogue of Mona Darling is so very famous. So you can remember this mnemonic with the name of Mona. So M stands for morphine and it has a class 1 and level C evidence. It is a standard analgesic which reduces the pain and anxiety during the ACS. But we need to be careful with the patients of hypotension, hypovolemia, and respiratory depression. O stands for oxygen, and we deliver oxygen to any patients of myocardial infarction who are hypoxic or whose oxygen saturation is less than 94 with class 1 evidence and level of recommendation as level C. So we need to remember this that you deliver oxygen for the patients only those who are hypoxic, and it has been shown that it has a limited benefit. In fact, it can be catastrophic or cause more harm if it is given in the patients with saturation of 100%. N stands for nitroglycerin. As we know that we deliver nitroglycerin in the form of an infusion as an analgesic, and it is a coronary vasodilator. But we need to be cautious in patients with hypotension, bradycardia, and tachycardia. And of course, A stands for the most important antiplatelet agent in the form of aspirin, to be given in the dose of 160 to 325 milligram as a chewable tablet, which causes irreversible inhibition of platelets and helps in stabilizing the plaques and arrest the thrombus. It has a direct impact on reducing the mortality in patients with STEMI. So it is very easy probably to remember this mnemonic MONA. So M stands for morphine, O stands for oxygen, N stands for nitroglycerin, and A stands for aspirin. As regards the various other antiplatelet therapy in the form of cangrelor, which is a reversible P2 white well inhibitor, and you could see that cangrelor in non-STEMI and STEMI would cause decrease in the morbidity and mortality, as well as decrease in the incidence of stent thrombosis. The other very famous antiplatelet agent is clopidogrel, and a newer antiplatelet agent by the name of Vorapaxar is been introduced, but at least I don't have any personal experience with the use of this agent, but we need to actually remember this. As far as the duration is concerned, as we know, standard DAPT for 12 months, both in STEMIs and non-STEMIs. There is increase in the bleeding risk when it is continued beyond 12 months. And of course, the other agent in the form of prasugrel, which decreases the stent thrombosis rate by about 50%, and ticagrelor, which will decrease the stent thrombosis by about 25%. But remember, the single antiplatelet therapeutic agent will always be aspirin. And this is a table which gives you the dosage of various antiplatelets which are given in this chart. So aspirin, the loading dose is 160 to 325 milligrams non-enteric coated tablet with a maintenance dose of 75 to 162 milligrams per day, and we classically give 150 milligrams in India, and it has to be continued indefinitely. So one antiplatelet agent for ACS patient to be continued forever will be aspirin. Clopidogrel in the dose of 300 to 600 milligram as a loading dose, followed by 75 milligram per day for the period of about 1 year. Prasugrel loading dose of 60 milligrams followed by 10 milligrams per day for about 1 year. Ticagrelor, loading dose of 180 milligrams, followed by 90 milligrams twice a day for the period of 1 year. So, this is a very important practical chart which we should actually remember. And I think I would like to stop here. As I said, this was a short video which discussed a few aspects of ACS as a part 3 video, and we'll meet in part 4 of my video on ACS in our next video. So that's all for now. Thank you very much. Take care.